Thank you very much for an absolutely fantastic talk. And if you ever fancy taking over the UK Ministry of Health, you'd be more than welcome. We need some technical people there. Anyway, fantastic. We're going to have a discussion now, and I'm going to ask to join the Minister on stage is Sophia Wilkinson from BBC Media Action, Ed Fottrell, who is a lecturer in epidemiology and evaluation here at the Institute for Global Health, and Peter Bias, who you've heard from already, Professor of Global Health at Umeå University in the northernmost reaches of Sweden. Is that right? And we've got a Twitter feed. I've been following the tweets. There's very lively Twitterati in the audience. And we need to pick up, what are these questions coming in? Funding to scale up, set achievable goals for successful solutions. I can't keep up. You'll have to follow. Right, we'll try and pick up. I'll ask somebody, because I'm not following, to make a note of any key questions, and we'll take some of the Twitter questions. So if you're online and you want to send a Twitter question in, mark it Q or something, and we'll take a note, and we'll try to answer it during the discussion. Okay, I'm going to open up the discussion now. Let's go from right to left. So I'm going to start with Ed, one of the key architects of this conference. Ed, your thoughts so far?
Thank you very much, and thank you, Minister Costello. What an incredible way to open this conference with, I think, such optimism and positive thought and case studies. And I think when I was listening to that, I thought mHealth is going to work and is going to achieve impact, and we're going to ever have evidence of impact. It's in the setting like Ethiopia, where you've got these, the health systems, the structure, the processes in place. The focus isn't on the technology. It's on the technology as a tool which would fit into the systems that are well designed and appropriate. I got particularly excited and interested in hearing about the health extension workers and about the model families, and thinking about data flows and data processes, and hopefully the data flows aren't just upwards, and I think you said that they weren't. And I think the idea of perhaps data cycles going back to health extension workers, going back to model families and citizens, to include them in mHealth processes, citizen participation, citizen ownership of mHealth, I think will be a huge area, perhaps not just for their adoption of the technology and of the processes, but perhaps as a way of increasing awareness of people's own health, and as perhaps a trigger to behaviour change and improved health. More generally, I want to extend kind of my welcome to everyone to this conference, and here in the room and also online. And as Anthony mentioned, this conference came about as an idea originally between Umeå and UCL and BBC Media Action as a meeting. Let's have a meeting to talk about evidence in mHealth in low-income countries. It gradually grew into a bit of a workshop, and now it's a conference over 2 days with over 300 people registered to attend, and a waiting list of over 100 people. And I think that interest has come because the focus has been on evidence. And as the Minister said, the evidence is key, that we don't focus just on pilots. We don't just focus on can we use a mobile phone in a remote area of Ethiopia, but on how is that kind of technology used to improve health? What is the evidence of improved health? And I think the fact that there's been such a huge response to this conference is an illustration of the clear need for that kind of focus. I think there's a need for a gear change away from pilots towards evidence. As part of the process of developing this conference, Peter, Sophia and Charles Hall and myself wrote this review paper looking at the evidence base of mHealth in low-income countries, and there's some copies outside, and it's an open access journal in Global Health Action. And basically from that we found there isn't a lot of evidence. There's some, the quality is a bit questionable in places, but there really isn't much evidence. Based on the abstracts that were submitted for this conference, I think if we were to repeat this review in 2 years' time, we'd have a different conclusion. There's a lot of work happening, and a lot is happening now. And I think that's very exciting, and I think maybe that makes this conference even more timely. So finally, I just want to end on a couple of my own hopes for this conference. Is that we do keep the focus on health outcomes, that we do focus not on so much on the processes and the implementation of mHealth, which is also very, very important, but we focus on how does it improve mortality, how does it improve morbidity. I hope that this conference facilitates new connections and collaborations that can then facilitate this gear change away from pilots towards evidence by sharing ideas, by sharing expertise and innovation that all of us have got in this room. And that this work isn't going to end after these 2 days, that we are going to hopefully continue a network. And whilst I am talking, I think you are receiving a survey by email, a nice mHealth example, but you're going to get a survey right now on your phones asking you about how you would like to continue any kind of collaboration here. How would you like to build a network of interested parties supporting one another in developing the evidence base for mHealth in their own countries?
Thank you very much. All right, well, we'll carry on and ask Sophia to contribute from BBC Media Action perspective. BBC being the British Broadcasting Corporation, probably the first and most extensive broadcasting network in the world.
Indeed. Thank you, Anthony. Some of you may be wondering, though, who BBC Media Action is and why we're supporting this conference. And I should say I feel very honoured to be sitting up here on this panel to represent BBC Media Action, particularly sat next to the Minister of Health of a country where we work. BBC Media Action is the BBC's independent international development charity, and we use media and communication to support people in low and middle income countries to improve their lives, and that includes around their health and well-being. The issues we focus on are maternal and child health, sexual and reproductive health, nutrition, hygiene and sanitation. And importantly, we use whatever form of media and communication reaches the people that we need to reach to influence social and behaviour change relating to health. Which brings me onto our interest in mHealth and our interest in this conference. Some 4 or 5 years ago, we became part of a Bill and Melinda Gates Foundation program in northern India, in Bihar, to reduce child mortality and improve maternal health. We'd already worked in India for a while, but mainly using television, because that is the medium in India that reaches most people. But in Bihar, it soon became incredibly clear that to reach the audience we most needed to reach, women of reproductive age, that we had to do something different. They didn't have access to television. They certainly didn't have access to radio, which is surprising to many, I know, because generally more people have access to radio than television. However, they had access to mobile phones. Our research showed 83% had access to mobile phones. And that's how we entered the world of mHealth. We weren't dazzled by the technology. As the minister said in Ethiopia, we are talking the most basic handsets used for making and receiving phone calls. And that's what we work with, appropriate technology. And for us, mHealth was all about finding a platform to reach people with life-saving information, with services to improve their health, based on the technology in their hands at this moment. And it's so much more than about sending messages, Anthony. I say that every time I meet you. But we could
exactly. No, I agree with you. Don't worry, I'm being provocative.
It was also about finding a platform that we could use at scale, and my colleague Samdeep Ghosh, who's presenting later on today, will be talking more about our services in India and the scale at which they operate. We're a donor-funded organisation. We rely entirely on raising our own funding, and quite rightly, donors want evidence before committing their money. Which is why we're interested in the evidence for mHealth, which is why we came along to UCL, I can't remember when it was, an awfully long time ago, to suggest that we hold some kind of workshop. And as Ed said, it snowballed into this event that we're really excited to be supporting to facilitate the discussion and dissemination of this evidence. And I'm thoroughly looking forward to the next few days. So let's get discussing.
Thank you very much. Okay, we'll move on to Peter, and then we'll throw it open for discussion. So start thinking about your comments and questions.
Thank you, Anthony. Just one or two very brief comments. Ed's already talked about the review article that we wrote in preparation for this meeting, and I'm not claiming it's the definitive statement by any means. There's a whole lot of mHealth stuff out there, but writing it was an interesting experience. Even, I have to say, a slightly depressing experience because, when you really start to delve around in the literature and see what is out there in terms of, we were looking specifically for mHealth applications of one kind and another in low and middle income countries that had been specifically associated with health outcomes. And there's not a whole lot of those. There's lots of mHealth applications, there's lots in low and middle income countries, but actually tracing the whole process through and saying, well, actually doing or having that particular mHealth idea has saved lives. Again, pilot studies dominate, as Costello said. That's one of the real difficulties. So mHealth is in its infancy. It's got some way to go yet before it becomes before it reaches a point of full potential. But nevertheless, even at the simplest level, and this is now having given you a little bit of doom and gloom, this is a slightly more optimistic example. One of the things that Costello's ministry has done is to make ambulances available in every district of Ethiopia, which is another of the very significant health achievements in Ethiopia in recent years. A district is about 150,000 people or something. Now, of course, you could say, well, why on earth weren't there ambulances 10 years ago, 20 years ago? There are various reasons for that. But even if there had been, at that time, those ambulances wouldn't have had any impact because nobody could have called them. So that's actually mHealth at the very simplest, most basic level, just being able to call an ambulance when there's a medical emergency in a rural community. And that's now a reality in Ethiopia, which is a massive change, I think, for the whole health system. Thank you very much.
Oh, thank you. Right. Okay, so I've been trying to follow some of the Twitter comments and feeds. One comment was, we've got to make sure we get the technology right because an awful lot of people don't have smartphones. They have very basic mobile phones, so we've got to adapt our technology to populations. Some comments about data exchange and analysis, and that raises the question, is there the capacity to analyse data that we collect? We used to have health centres full of paper that wasn't analysed. Are we just now getting databases? So there's a capacity issue. A lot of talk about pilots to scale up. Some people saying it's all pilots and that's a real problem. On the other hand, some people saying, well, you always have a lot of pilots if you're going to end up with one or two projects, so we shouldn't worry too much about the number of startups. I liked Alan's comment about helium-filled reports that go up into the air and never reach the people that it's going to benefit. Also the comments saying, look, we know enough about the benefits of mHealth for appointments and treatment adherence particularly. We don't really need more evidence there. We could actually take those to scale. Is that true or not? And then a comment that we do need to focus on health outcomes and to see what the impacts are. And then another observation that there are more mobile phones than toilets in India, and therefore we've got to make use of this technology and the power. Okay, the floor is open. Comments, questions. When you make a comment, try not to make it too long and say who you are and where you're from. Yes, there's one there, there's one there.
I'd like to ask a little bit about false consensus. We here at mHealth
Just wait for the microphone because we've got an online audience of millions.
So I'm David Doherty. The question I have is, we're here at an mHealth event. We all know this is going on, but obviously, people out there who are deploying things in hospitals probably don't even know that someone calls this mHealth. They're just using their mobile phone to be with people. So talking about a lot of stuff being pilots, surely the majority is actually clinicians, patients who are carers that are deploying things. We're just not picking it up. I mean, what are we doing to make ourselves more aware to these people, that these events and opportunities to come and present their findings here, instead of obviously seeking funding for pilots and things like that? What would your advice be to people maybe on the online stream who heard about this too late, couldn't get here because the seats were all sold out? Maybe we should use some technology there.
Yes. Okay. Okay, that's one. We'll take three and then we'll ask the panel. So there was a question there and there's one there.
Hi, my name is Seb Roberts. I'm a A&E doc working in Kent. This question is directed mainly at Dr. Adamasu. Thank you very much for your enlightening speech. I'm particularly interested in the data capture processes which you talked about. So obviously you've mentioned limitations of technology. Can you potentially elaborate on how you potentially track outcomes? Is it paper-based? Is it tracked through a mobile system? How does that actually come about?
Thank you. So a question about tracking outcomes, one about reaching out to people already using it, and there was one down here.
I've got a microphone.
Oh, you've got them, yeah.
So I'm Delia Lloyd. I'm the Senior Policy Manager at BBC Media Action and part of the team that put the conference together. It's really exciting to be here after all these months of preparation. I have a question for the Minister of Health, because I'm really taken with the model family idea, and the reason I like it is it's incentive-based. So you're looking at what motivates citizens on the ground. Everyone apparently wants to be recognized. They like these rewards. They go to a fancy ceremony. My worry is, what happens how do you keep that going? Because presumably you get rewarded, you do the nets, you do the toilets, you do the whatever you do, and then you're a model citizen, you get the gold star. What keeps you going? Well, how do you sustain that model citizenship around health at the community level?
Lovely, thank you. There are three good questions. Okay, well let's go through logically. The first one, reaching out. Should we have accepted more people? Anyone? Ed?
Yes. We've made every effort we could to reach out. I think you're absolutely right. There's no point talking about anything in low and middle income countries unless low and middle income countries are leading that discussion and very much participating in it. We've tried, and I think we did eventually get quite a wide reach, judging from the responses that we've got and the inquiries that we had from Rwanda, from Somalia, from Singapore, from India, Bangladesh. We do have a representation of some of these countries in the room, and hopefully many more online who hopefully don't feel that distance is such a barrier. We want them to participate as much as they can electronically. The issue was money. We did this whole conference on a shoestring, and the sponsorship that we did receive, we have used entirely to bring people over to sponsor delegates from low-income countries. I think a lot more can and should be done. If we do this again, let's get more money, let's get more people, let's hold it somewhere else, maybe closer to those settings.
Just to follow up on that, I think...
Skype's good.
Yeah, but there's a broader point there about the reach of technologies and reaching out to populations. We have this assumption that everything is led by donors or ministries, and yet the mobile phone is a great example of a technology that everyone realised was valuable and just spread across the world like wildfire, with no assistance actually from ministries or donors or whatever. And
Mohammed Ibrahim would disagree with you.
Sorry?
I saw Mohammed Ibrahim when he was doing his work bringing mobile phones to Africa, and he would disagree with you. He was up against some massive barriers. It wasn't just adopted everywhere. There was a lot of hard work.
No, of course you go through a transition, but a lot of it is demand-led. It's not actually just about a supply side from the top. I mean, he's a commercial guy.
He had to build a network first. You couldn't use a mobile phone.
Of course. I'm not saying governments don't play a role in that. But nonetheless, it shows you that the power of populations taking decisions and secular trends are often beyond the reach of donors and specific sectoral ministries. And I think we have to remember that, and we have to tap into that. Okay, the second question was tracking outcomes. Peter, do you want to answer that? Or it?
Well, yes. I mean, I think it's critically important, and I think just because mHealth is viewed by some people as a bit of an alternative kind of approach to handling some of these health issues, to me that doesn't mean that it shouldn't be just as subject to the outcome measurement as any other kind of bit of health would be. And I mean, you and I and many people in the audience come from backgrounds of measuring health outcomes in one way and another, and it's not sufficient to say, oh well, this is mHealth, therefore it must be good. We don't really mind about the outcomes. I mean, it's just like a drug or a treatment or a women's group or whatever else it is where you can measure outcomes, and I think that needs to be done. On the other hand, we shouldn't kind of sit around and say, well, we can't implement any mHealth because we haven't measured the outcomes yet.
No.
There is a tension there.
Well, did you have a more specific question about how outcomes are measured?
It's more about how the processes are currently working in Ethiopia.
I think it was for the minister.
Oh, I see, at scale in a government system.
With the limitation of technology.
Do you, I mean, presumably a lot of your mortality rates come from things like DHS, but do you use your routine data collection in a mHealth format and to analyze administration?
Yeah. In Ethiopia, our health management information system is based on a paper-based system. Now, for instance, our health extension workers collect information, including vital statistics, using what we call a family folder. So every family in the country has a folder. So we have 18 million family folders. And my vision for the future is, can we digitize these 18 million family folders? And can you really, use mHealth and other tablet computers and so on to collect the vital statistics in every family, using that. But at the moment, our system is paper-based, that is collected from the health post to the health center, hospitals, and so on. But we have also started what we call electronic HMIs. And the electronic HMIs is starting at this point in time from district health office upwards, because that is where we mainly have, this internet connectivity and so on, using broadbands. We have what we call the district net or Warada net in Ethiopia. So we use that platform to collect electronic HMIs from district upwards. So the health posts and health centers send their health information system and the data that is collected using a paper-based system to the district, and from the district upwards we have the electronic HMIs. And we use electronic HMIs to generate a scorecard. So in Ethiopia, if you go to the regional president's office or to the district governor's office, every quarter we send out scorecards, how they have done, as compared to the district next door and to the region, to other regions in the country. So we use HMIs to, again, generate electronic scorecard and send out to the politicians at different levels of the system. So that is how we are using, but as the country is massive, the population is huge, we really want to encourage our health information technicians at the lower level of the system to use as much data as possible to influence their planning and programming activities at lower level of the system. The orientation of the system for a very long time is collect the data, collect it and send it upwards. But what we really want to change is use the data at level of data collection, to improve quality of care, to improve program. And that's why we are introducing these health information technicians. So they will not only help us collect good quality data, but they will also help us improve the decision making based on that data at the level of data collection.
Thank you very much. The third question was about the sustainability of the model family and gold award system. It's a great idea. Is there an inbuilt sustainability, or do you think you have to go back and keep it going?
It is something that we are currently thinking, because now we have started a visioning exercise until 2035. So in fact we call it visioning exercise in the health sector to achieve universal health coverage by 2035 using primary health care. And we identified 6 important pillars, and one of the most important pillars, the first one, is community engagement. And how do you keep the community interested? Today malaria is a problem. So getting information, getting the skills, the knowledge to prevent malaria motivates the community. And they want to do that. But when we significantly reduce the incidence of malaria, and when malaria is perceived to be no more a problem, how do you keep the community interested? How do you make them, engaged in health sector activities? So we are currently trying to test 2 models. The first one is, if you look at our health extension program, according to the Ethiopian educational standards, our health extension workers are called level 3. So their competency is called level 3. So can we certify our model families to be level 1 if they acquire certain competencies? And a few years down the line, can we again properly educate them, integrate it with the adult education program that is going on in the country, and upgrade them to level 2 and level 3. So by the time they become level 3, if there is a vacancy available within the community, they can be hired and be part of the system. So they can aspire to follow this path. But the second one we are piloting, which is really making good progress in some parts of the country, is this idea of having not only model families but model neighborhoods and model villages and so on, and to create this solidarity within the community and to provide that social safety net. And we use the community-based health insurance scheme we are piloting in these parts of our country to really mobilize the community so that they not only make disease prevention possible, but they also extend the social safety net using community insurance, community care coalition, caring for orphans and vulnerable families and so on by contributing some resources and so on. So we are moving from model families to model neighborhoods and model villages, and this will also in a way sustain and help the community more interested.
Can I just, a quick question on data. In some countries, and certainly say some states of India, there's a huge mismatch between official returns to ministries on coverage indicators, say immunisation or whatever, and then independent surveys that may show that the coverage is actually half what the official statistics are. So if you have a target culture where people are incentivized to achieve certain targets, there is always the pressure for people to cheat. And that happens everywhere. It happens in surveillance systems. How do you get around that issue, and how do you maintain quality of information collection and reporting?
Yeah, that used to be a problem in the early days of our health extension program as well. We were just looking at coverage data using HMIS, and the discrepancy between the surveys and the HMIS data was huge. But the introduction of the family folder has changed that.
Has it? Yeah.
So in rural areas, in the past, you don't have household numbers, for instance. So you just tally and post 100 children have been vaccinated. But now, you know, on the tally sheet and on the family folder, you have to really register which child from which household has been vaccinated.
Yeah.
So the supervisor, since we have a dedicated supervisor at the health center level, when they go out, they not only look at the tally sheet, but they randomly go and check at the household level. So the introduction of the family folder has been a breakthrough innovation
That's
for
interesting.
our health system.
Thank you. Take some more questions. There's one there, there's one there, there's one there, there's one up the back. We'll take 4, and then we'll take 3, and then we'll come back. We'll do 2 more rounds. Just.
Francis Griffiths from the University of Warwick. I want to ask a question that's also been raised in some of the tweets that are showing behind you that you can't see. We're talking about health outcomes, but there is quite a good argument to be made that actually it might be a process outcome that we need to be assessing, because often we know the evidence for the other parts of the system that lead on to the health outcome. So to take your example, Peter, mobile phones enabling people to get emergency transport to a hospital or setting where they can actually then have safe delivery of their baby. Well, we only need to measure that the mobile phone helps them get into the ambulance and to the place. Then it's a different issue. So, and quite a few comments have made this point as well.
Thank you. Process outcomes. We'll take one here.
Hello, my name's Hannah Clark and I'm from FIBA Radio. I think this is a question more for Sophia. I was fascinated and encouraged to hear that mHealth is not just about sending messages. So in communities with low literacy and very basic mobile technology, what other applications are being used, particularly related to audio, within the mobile technology sphere? Thank you.
Thank you. And we'll take one more. I think, who's got the mic? Take one there.
Thank you. My name is Isaac Coleman. I'm with Medic Mobile and University of Cambridge. And my question is about this health outcomes evidence focus and the question of are mHealth interventions replicable? There have been a few systematic reviews in the field of e-health suggesting conflicting evidence or non-replicability. Sometimes they do work and improve health outcomes. In other situations, the same interventions don't. In my own field of organization studies, this has been pretty well established since the 80s that the causal relationship between technology and organizational outcomes is highly dependent on the specific circumstances of implementation. And so there are people studying this question of replicability of intervention complexity and this whole idea of global health delivery research. My question is that stream of research going to proceed in sort of a separate silo or a separate stream from mHealth research focused on, trials measuring health outcomes? Or are there ways that we can integrate these streams of research? And if so, I'd be very interested to hear your thoughts on how we might go about that.
Thank you. Very interesting questions. So we've got 3 quick. Who wants to answer about using process markers as outcomes rather than ultimate health outcomes? Ed?
That's something that we thought about a lot when we were starting to look at this review paper. We quite clearly found lots of health outcomes, tangible health outcomes, whatever that exactly means. And I think what we concluded was that, process outcomes can be, and if there's a strong evidence link between the process and the health outcome, so uptake of antenatal care, minimum visits, or ability to access ambulances, for example, there's a clear pathway with evidence based from the process to health outcome. If the mHealth is improving the process, then I think that's fine to focus on that. The issue where we want to move away from process or implementation in the sense of the community health workers were able to use the phone. We were able to have a mobile signal. Even things like the messaging, the idea of mHealth, kind of traditional view, if you like, of mHealth interventions as a health promotion messaging system. The system or the process might work. People do receive the messages, but actually does that lead to any better health outcome?
Just, can I interrupt here? Because a reason to be quite tough on health outcomes. Good examples, transplanting stuff from wealthy to poor countries. The recent example of antenatal steroids. A year ago, huge campaign from major funders. Let's scale it all up. There's systematic reviews that show it saves preterm babies' lives. Kishu Azad, who's sitting in the back there, paediatrician from Bangladesh, and I wrote an article saying, be very cautious here. We don't know if this will work in low-income countries. It could actually have adverse effects if you're injecting millions of women. The big trial has now come out. It's just been published online in The Lancet, which showed that when they did a big trial in low-income countries, it kills babies and it makes mothers more vulnerable to sepsis. So we have to be very careful that assuming that things work, even based on systematic reviews in very wealthy settings, don't always transplant to low-income countries. So we have to be a bit skeptical about things. But you can't do trials on everything, and I take your point. One should always build in reliable process indicators. And it comes back to the contextual stuff that we'll come back to. But very quickly, Sophia, on apps being used for low technology phones in largely illiterate communities.
Yeah, I mean, my point about it's more than just sending messages. None of our services are text-based because the people that we're serving have low levels of literacy. So we use voice recorded. I don't even really want to call them messages because I think of our content more in terms as short programming, and it's I guess slightly more akin to radio programming than just sending messages. But just let me give you an example, a couple of examples of our services in India. One of which is called Mobile Kunji, which is a service which is used by frontline health workers when they're interacting with families. It consists of a traditional deck of cards with around different issues, antenatal care, how to feed your baby when it gets to 6 months, etc., etc. But each card has a short code on it that the health workers can dial when they're speaking to their families, and that short code links them through to a recording of the doctor supporting and reinforcing the information that is on that card. It is a message in some ways, but it's been extremely cleverly designed. The doctor speaks in rhyming couplets so that the audience remembers what she's saying. It's been extensively tested with the audiences so that it resonates and appeals with them, so they're not just receiving a text. And I think very importantly, they're actually choosing to dial into this content. It's not kind of random SMSing. My heart sinks when I read about random SMS projects. There was one, I think it was Guinea for Ebola, and the people responsible were wondering why it appeared to have had no effect. Well, it's because the audiences they were randomly SMSing couldn't read. And it sounds so obvious, but those mistakes are made. My feeling at the moment is that with very basic feature phones, or even more basic than that, is that services that are mediated in some way will have more impact. That's just my instinct. Where there is a mechanism for discussion around that content, I think, is probably going to lead to greater change. We do have services that are non-mediated. But my instinct is that the mediated will have a greater impact on behaviour change, which is the process we measure rather than the
So
the
that's
health
a
and health outcome.
really interesting and important point. So using the phone to create a relational situation whereby you're giving a story or a verbal message rather than something that is just. Well, it's more than a message then.
It's generating a conversation.
Exactly.
It's supporting and reinforcing. It's really importantly, I think, building the confidence of the health worker who is discussing with the family. And I don't want to crash into Sandeep's presentation later because he'll be talking. He'll be talking more about that.
We'll come back to that. The other question, which I thought was great, was about the contextual issue around replicability and how can we, in our studies, merge an analysis of context, and maybe this is an argument for doing things at scale, so that one can look at where it works and where it doesn't. Anyone want to comment on that?
I can comment just briefly that I know we think a lot about whether our mHealth services are replicable. Yes and no, they absolutely have to be designed in the context that they are going to be operating. An awful lot of user testing has to go into the services to find out. I'm talking about kind of families and the general population rather than health workers at this point in time. But we need to know how people actually use their phones, when they use their phones, what they want to do with it, what they can do with it, whether they can navigate through menus, whether there are the in the situations of where we have mediated services, who are the mediators? How do health workers do their job? Are they out in the community or are they sat in clinics? Are there women's groups that are functional that we can tap into? There's a whole lot of things, how the mobile networks operate.
It reminds us with trials, you're not just interested in the impact statement at the end. It is all about mixed methods. It's about qualitative studies, looking at why or how it did work or didn't work. And negative studies are as important as positive. They don't mean the technology doesn't work. It may just not have been implemented correctly. And so we have to do, this is a huge boon for social scientists and anthropologists. It's as important as the epidemiology. We have to bring both together. I absolutely agree with that. Yes, there's a waving arm at the back. There's one there, and there's one there. That looks like a veterinary question. Right, let's take one. We'll take the last three. Oh, are we over time? Are we?
Yes.
Oh my goodness. Right, really quick. You're allowed 10-second questions and comments.
10-second comment, completely reinforcing what you've just said about content. I'm Carrie Free from the London School of Hygiene and Tropical Medicine. I work in high, low and middle income countries, so sometimes we use text messages and sometimes voice messages. But just to say that when you use a message, a text message, it isn't just a message either. Lots of user testing has to go into it. It has to involve behaviour change techniques. The effective text-to-stop and stomp trials for smoking cessation involved 16 different behaviour change techniques, and lots of the behaviour change interventions don't work because there's contained one or two techniques or information only, not written in a particularly appropriate style or tone. And tone is also a very important element of the text messaging intervention because it needs to be supportive and empathetic and take into account context. So
thank you very much.
It's not just a message for anyone.
Really important coming across. Don't use the word messages. Talk about conversations. Right, we're going to have a comment here. Yeah.
Thank you very much to sort of again acknowledge the high level discussion we have had. I want to support the focus on sort of health outcome because I think.
Sorry, where are you from? And
sorry, I want to save on time. I work with Concern Worldwide, based in New York. I think in many contexts we still need to provide the right information to shape appropriate health-seeking behavior, and that's why I think focusing on health outcome beyond the processes and data will be important. And maybe to hear from the Minister of Health, I just did some quick math to realize that, to see that one health extension worker will cover about 600 women of reproductive age. So one every 2 years or something like that. So given the priority that you have listed here, do you see also still some gaps or opportunity of mHealth to help reaching the target population?
Okay, so that's a coverage question. We'll have one more. By the way, you just got out of New York in time. It's all closed down. The whole city. It's Nick Short,
Thanks. My name's Nick Short and I am a vet from the Royal Vet College. Excellent discussion. My only concern is really that I think we have to be cautious not to be seen to be proposing top-down solutions. which based here in the UK, and perhaps don't take into account the full breadth of the kind of spontaneity, almost the anarchy of the internet and the phone networks that we see actually in the countries we work in. And I say that, for example, just a couple of things I've seen working in Kenya, where we've seen community workers using Twitter and Twitter SMS feeds to develop a network to share experience of disease outbreaks in their own community. Or also, I'd like to suggest that, being a vet, that we make sure we have inclusive models so that we actually bring in vets and medics together into the same sort of community and look at how these environments can actually be much more evolving. And I suppose my final point really is that if you look at what's really driven mobile developments in this country, and to some extent also overseas, it's very much the commercial and private sector, whether it's a kind of individual app developer in his bedroom or whether it's a kind of innovative kind of commercial company. I think that's something we need to work closely with. While I really subscribe to mHealth, and I think we do have a major role to play in actually providing some direction to what we need to do in the way of collecting information, dissemination of knowledge, I don't think we can do that in isolation. So a much more inclusive model, I think, would help us in actually kind of producing results.
Great, thank you. So don't be top down from a veterinary anarchist or entrepreneur, whichever you wish to be. Okay, I'm just going to take a final response from Minister.
You missed a question for the top one.
Sorry?
You missed a question.
Did I miss a question?
Yeah.
I beg your pardon, we'll take one final comment question, then the Minister, then we finish. We did start late.
Thanks very much. I was very persistent. Thank you. Trish Groves, I'm the head of research at the BMJ, the British Medical Journal. Hello. I wondered if you might be able to talk about evidence on actually reaching health researchers using mobile apps or text or whatever. So actually supporting researchers so that they can develop good research questions and do good research.
Yeah, that's a very good question. Okay. Very quickly, from the Minister about coverage, and anyone else about reaching out to the health research community if they're not on Twitter.
Yeah, as part of the model family training program we recently, some 4 years ago, 4 or 5 years ago, we also launched what we call the Health Development Army, which I forgot to mention earlier. So we have 3 million women volunteers who are, health development army or graduates of the model family program working alongside with our health extension workers. So we have, in addition to one health extension worker for 500 families, we have what we call, these 1 to 5 network leaders. So for every 6 households, there is one model family that works with the health extension worker, that helps the health extension worker prioritize and so on. So in areas where there is better mobile penetration and better coverage, the network leaders and the team leaders of those women groups interact with the health extension workers using mobile phones. So we want to introduce some kind of intervention to facilitate the discussion and information exchange between the health development army and the health extension workers.
Any quick response to Trish Groves from the BMJ, who are a partner in this conference? Fantastic.
Just quickly, and this is very idealistic and not going to happen this week or anything like that, but I do see potential in the long run for as data becomes more a part of everything that health services do, and as data obviously is what researchers feed on, I can see the possibility for some kind of convergence in a big data sense. The fact that we've got 18 million family folders in Ethiopia, which may become digitized, and, then you've got huge possibilities of national scale research instead of all these fiddling little surveys and so on that are done in different places. And I think that's a long-term vision.
And if we did all publications and peer review online, we wouldn't need journals like the BMJ and the Lancet.
I couldn't possibly comment.
Sorry. Okay, that's been a fantastic discussion. You have 1 minute now to stretch your arms and legs and relax and cough and breathe And we're going to thank the panel.